Thank you, Anish, and thank you for inviting me to give this talk on the whistle-stop tour of femoral fractures in children, what to do and when. So femoral shaft fractures represent around 2% of all pediatric fractures in kids, and there's really a bimodal distribution. Either you've got your toddlers who are sort of falling over, tripping over, falling from heights, or you have your adolescents who are involved in higher energy injuries, and this could include anything from sports to some motocross driving and road traffic accidents. And just as Claire spoke about, non-accidental injury is something that should be on top of your mind, especially when you see a child who's of non-walking age. And there have been studies to show even a high proportion of these non-accidental injuries in kids sustaining isolated femur fractures at age 3 and younger. And obviously, as part of that, they need to go through a workup. So it's important to find out when the index injury was, because delayed presentation is obviously part of that as well. The clinical presentation varies quite a lot, from swelling, crepitus, and pseudoparalysis in an unsettled toddler to obviously quite a traumatic injury, as you've seen here on the football pitch, where a splint has been applied by the ambulance crew and they've been brought into hospital. The key is taking a really good history and examination, assessing neurovascular status, and in these higher energy injuries, especially road traffic accident, continuing to manage the patient with ATLS protocols to ensure they're physiologically stable and that the management of their pain is satisfactory. When it comes down to imaging, really, plain radiographs and tube planes are sufficient. However, further imaging like CTs, MRIs can be used if there's concern, if there's any sort of pathological element to it, or if there's extension into articular service. And fractures can be classified using AO classification, but really it comes down to, is this length stable or unstable? And the goals of management are to restore the length, rotation, and mechanical alignment. Respecting the vasculature, be it proximally around the femoral neck or the periosteum, which obviously provides a huge amount of bone healing, as these largely heal by relative stability through indirect bone healing, which is why we see callus on X-rays. And to protect the physis, always protect the physis. Pediatric orthopedic surgeons don't stop talking about the physis, and that's largely when we get down to these flexible nails that you can see here that have thankfully avoided. Rockwood and Green published the acceptor angulation in these patients, and as you can see, the older you get, the closer you get to skeletal maturity, the less you should tolerate and the more active you should be in managing these patients. Now, there needs to be a clear strategy when managing these patients and their fractures, and it is multifactorial. So obviously, we need to know the morphology of the fracture. We need to assess the patient's habitus and the robustness of the soft tissue envelope. The cooperation and understanding of the parents. And the young child, the average time a parent needs to take off work is 3 weeks. And so it really is forming this therapeutic alliance with them and explaining it to them in such a way. And then finally, it comes down to your own experience, skills, and expertise. But to really sum down this talk, we're going to go through the way of my management according to age and the size of a child. So infant presentation of femoral fractures can be due to obstetric causes. This can happen with breech presentation, instrumented delivery, when there's twin births or there's evidence of maternal fibroids, or can happen as they get slightly older. And again, we need to be ruling out non-accidental injury with that. Gallows traction, as sort of shown here on the left, is really a thing of the past now. And, because it involves high intensity nursing, daily skeletal traction changes. It can have high risk of nerve injury and skin damage, and a long time for the patient and the parent to be in the hospital. Because they heal so quickly and they have such an amazing propensity for remodeling, the mainstay of treatment is really a Pavlik harness in this age group, which really allows for ease of care and reduced hospital stay. And everyone and every trainee should really learn how to put on a Pavlik harness for DDH and for trauma. And it's relatively simple, but looks quite scary when you first see one. If you do have a patient who's got a very subtle fracture, as shown in the bottom right-hand image, a toddler and who's slightly bigger, then abduction brace is also another acceptable method. And I'll take you through a case of a Pavlik harness just to show you how quick these patients heal. This patient was born with the femoral fracture. We were called up to the intensive care unit to see them, and we put them in a Pavlik harness. And you can see the development of callus so quickly within a fortnight at 4 weeks. At 12 weeks, there was almost complete straightening of the bone, and we've now followed that patient up to age 2. The main thing with these is to potentially alert the parents about leg length discrepancy in the future. Although I'm not seeing this patient anymore, they're aware if they have got any concerns, they can always come back and see us. Now, 6 to 5 month olds, I would say, again, there starts to become some controversy over the management. However, I would say the main management described in the textbooks and in my clinical practice is application of a hip spica, although there has been a trend more towards surgical management with nailings in sort of 4 and 5-year-olds, although there's very similar outcome. When you first see these patients, what you want to know is what is the energy of the fracture? Is it a low energy fracture or high energy fracture? And what is the degree of shortening? And essentially, is it less or more than 2 centimeters? If it's a low energy fracture and it's less than 2 centimeters of shortening, then I apply an immediate hip spica on the day of presentation or day after of presentation. And I'll talk through my method and the way that I do this, which is with a walking hip spica. It's been shown to let patients walk earlier, reduce the amount of skin problems, reduce the length of stay in hospital, and obviously for patient analgesia. If there is a higher energy fracture, then still skin traction can be used on the wards. And again, always speak to the pediatric ward staff and make sure that you have a setup for skeletal traction on your pediatric ward with a delayed application of spica. And obviously, if there is a significant amount of comminution or fracture is segmental, then submuscular plating is something we'll talk about as we get to our sort of older age group where we tend to see that. And this is an example of a child who was put into a hip spica, as you can see at week 1, the development of callus at week 6, and the subsequent remodeling on the AP and lateral at 6 months. So the walking hip spica technique has been shown to reduce the requirement of wheelchairs and ambulance transport and allows for early weight bearing. We do this under general anesthetic in theatre, and you need a spica table or a spica table attachment for this. The first thing is to have II there and ensure that you can apply some traction to the fracture. We apply a cylinder cast, so going down to the ankle from the upper leg, holding the knee at 45-degree of flexion to relax the hand, to sort of stress out the hamstrings as much as they can tolerate. And the most important thing is to apply a valgus mold at the level of the fracture, because the adductors want to pull the distal fragment into varus. You do that under II guidance to ensure that you've achieved appropriate valgus on there. And then you extend it proximally to obviously come across to the belly and up to the level of the nipples. Now, the main issue with this is in some earlier studies, they found that a lot of these fracture casts broke when patients started walking on them. So we reinforce it anteriorly, which unfortunately hasn't projected well here. So I've drawn a marking of where we put our, this is a case I actually did yesterday. Just so happens we had one yesterday. And that allows it to be strengthened up at the front before applying, your colorful, and we like to enjoy decorating them with glitter, or as you can see, the permission from the parent here to show the boy very happy with his Hulk plaster and matching clothes. That same boy, he sustained this injury last June over the COVID lockdown. He was on a trampoline, and I'm well known as a trampoline Grinch. But this is his presenting fracture, AP and lateral. You can see with a valgus apply, we had a good reduction, and this is the level that I marked the plaster at. I'll go back to the last slide. You can see here there's a mark on the plaster, and the reason we mark the plaster at this stage is because if it does drift into varus, which tends to happen in the first 10 days or so, you can do a medial wedging in the outpatient department. I've only had to do that once out of the 8 patients I've treated with in this case, but that's what me marking it here using just a metallic guide for that. We then observed him at day 9, was happy with the amount of varus that we'd accepted there. And as you can see, this was his x-rays at week 8, but he actually began walking at week 4 onto the plaster. And this is demonstrated here. This is our young lad walking, same boy at 4 weeks, unassisted, assisted. He was standing by 3 weeks. And the best part that patients and parents have responded to this is it's so much easier to find seating for them. That's at the dinner table, in a pram, in a car seat. They're able to get more comfortable when sleeping, and even allows for parents to hold them without having a plaster digging into them the whole time. So this is something that I'm quite passionate about doing in my patient group. 5 to 11-year-olds is really where the controversy starts to come in, and I'm sure Dan Perry will think about some sort of femoral shaft trial as we get into more pediatric trauma trials in the future. And it really is sort of dependent on surgeon and fracture factors. Again, thinking about the mechanism and the presentation of the fracture pattern, the patient's body habitus, the soft tissue envelope, and the equipment and technical knowledge, and can range from submuscular plating to intramedullary nailing to the use of X-Fix in higher trauma injuries. Now, flexible nailing is a key technique that everyone knows, I'm sure, how to do, especially when it comes down to forearms. For femurs, it may not be appropriate in patients who have length unstable fractures or ones of the proximal distal third of the femur. Flexible nails should be of the same size. They should be pre-bent and expand, have a maximum spread at the level of the fracture. And the best part is you can use them up into patients of around 50 kilos, which we can do more for our patients here than in America, I'm sure. They come in both stainless steel and titanium variants, and there's no real difference in the outcomes between the two, except for the stainless steel ones being significantly cheaper, about a third the cost of that. The goal is to fill around 80% of the femoral canal. And the best part is this doesn't risk any AVN or have any issues with regards to touching near the physis. So as you can see here, patient is supine, the nice position with a contralateral leg abducted, so surgeons can get on both sides, using a drill or awl in a retrograde fashion, although you can do this in antegrade fashion, passing the nails up to have maximum spread. And this allows for early weight bearing again, although I have to say most patients are quite reluctant. So the involvement of early physiotherapy is really helpful for this. And there are adjuncts that you can use to assist reduction, and that includes this F tool here. You can use a joystick with a sort of Steinman pin, and this was in a quite complex segmental fracture that Teddy Schlongo presented on. And if you're struggling and you're 20, 30 minutes into the procedure, I would just do a mini open to help pass those nails across the fracture site. The use of end caps, as shown here, has been shown to increase the stability by almost 6 times the amount of force you can put through that fracture, although complications with them and with nails in total is really knee pain and irritation with subsequent require for removal. They can drift into malunion, as one of the cases in the pre-cases showed, and that's largely due to them not being spread out efficiently. They're not just to splint internally. They work best with the elastic stability and them having the maximum spread. With regards to submuscular plating, it's typically used for those other fractures, the length unstable, comminuted fractures, those with the butterfly fragment, or those with proximal distal third or pathological in nature. They work usually in a bridging mode, and the working length, which is essentially the length from the distal most proximal screw to the proximal distal screw, is exactly like an external fixator. So essentially an internal external fixator, as we talk about, with a long working length. They can be pre-contoured, and then how we do it with regards to direct, indirect, or percutaneous reduction, really, you're having decreasing stability, but you're preserving the biology more and more by not disturbing the periosteum. For these complex length unstable fractures, they have a significantly better reported outcomes compared to intramedullary nails. They have a sooner unassisted full weight bearing time, reduced time to union, reduced surgical time, reduced amount of malunion. Although obviously complications yet again can include issues with leg length discrepancy and the risk of refracture following removal. And here are 2 cases: an 8-year-old who was involved in a car accident who had large butterfly fragment and submuscular plating done with excellent healing, and a 12-year-old who had a bone cyst with suspicion on the presenting x-ray. They had an MRI to confirm that, and we did this avoiding the physis distally. I've had a recent one with a proximal lesion, and again a more recent one with the distal non-ossifying fibroma we've treated in the same way. Finally, as patients hit that second peak, the injuries tend to be more higher energy, and obviously there's a lower propensity for remodeling, and therefore really these solid intramedullary nails are the mainstay of treatment. Now, the way they differ compared to adult nails is obviously their insertion point, which is either on the lateral tip of the trochanter or on the lateral part of the trochanter. And that, I recommend everyone knows what's available to them in their operating theatre, and most units don't hold these, so find out which one you would bring in, because there is a significant variation in the available diameters and the opening reamer sizes, and also in their entry points. The orthopaediatrics and Synthes nails enter here on the lateral most aspect of the trochanter, which is at the level of the base of the femoral neck, whilst the Smith and Nephi nail actually comes a little more medially than that, as sort of demonstrated here. They the isthmus in these patients is very tight. So you do need to be wary of that and preoperatively plan for that. We expect reaming, I would ream up to 1.5 millimeters more than you need just to have ease in passing that nail down. It can take a huge amount of force to knock these nails down. And they do have an anterior bow. So you'll notice when you put them in, and as you insert them down, you're rotating the jig 90 degrees to allow entrance of that. Again, some tips and tricks for reduction, anything from the F-tool to a distracting external fixator, using blocking screws to ensure adequate reduction, and even in a couple of cases, applying a tourniquet across the site to increase the compartmental pressure to aid your reduction to pass that guide wire in the first place. Being wary of the amount of rotation is really important, and you can use x-rays of the contralateral limb to sort of assess your distal femur and proximal femur, and you don't want to be fixing these and end up with a patient that intoes or outtoes significantly, as that might then require some degree of revision. And again, the benefit of these is they can immediately weight bear. They have very low rates of AVN when using the lateral entry nails, and they very rarely have any significant malunion. So a very, very good implant indeed. And I think the role of solid nails is actually being, especially with these smaller nail sizes, as you can see, means that they could be used in even younger age groups than 11 years. So in summary, we've covered the whole spectrum of management of femoral shaft fractures, really done by age. And I hope this is the only slide that has a lot of writing on it for us to sum it all up. Thank you very, very much.
That's great, Pranai. Thank you very much. That's, again, very comprehensive, and it gives everyone basically an algorithm, doesn't it? So if you're doing the FRCS, that last slide is a really good one to use for answering your questions. In real life, we all know that you can never say never or say, I always do this. And as you kind of stress, I think it's dependent on the case and the patient. Now, we've had a few questions. I've been answering some of them on my own because there are a lot of questions. One that I think specifically for you, Pranai, Shinil Koshi has asked, what's the flexion degree at the hip and knee in that spica?
45 degrees at the hip, knee, and 45 degrees at the hip.
Brilliant, thank you. And then this is a difficult one. What is the definition of the axial stable fracture? Is that a static or a dynamic term? It depends on whether you're walking past the X-ray or you're looking at it intently, I think. But what would you say?
So just repeat it again for me, Anish.
What's the definition of the axial stable fracture? Is it static or a dynamic term?
I think, for me, it'll be a dynamic. Because you want to be able to weight bear on it, and as I say, this is where the transverse fractures, where the sort of flexible nailings and where your solid nailings are. It's when you're dynamically walking on it, it remains to be stable. I think that's probably the answer for that.
And then again, I'm going to ask everyone this, if you guys all unmute yourselves, but someone's asked, is there any role for examination under anesthesia for axially unstable fractures? And if so, how would you do that? And it says here, and do the measures of shortening. So does anyone EUA a fracture, a femoral fracture, without a plan to do something definitively?
I think most of our trainees who see these patients out of hours tend to consent them for absolutely everything. And that's probably just because of the way they've been trained, so they say, oh, we'll put hip spike, or we may put some metalwork in and we may nail it. I mean, we've all done that as part of our training. I think normally when you look at the fracture pattern, as I said, the main thing to know is this length stable or unstable? And what is the degree of shortening? And I think those two on your presenting X-ray, where very enough patients are tensing, so they have muscle spasticity and are really shortening it as much as it's going to go, that will give you an answer enough as to what you need to do.
Yeah. Sorry, Claire, yeah.
So historically, so we don't put an early hip spica on. We keep them on traction for 7 to 10 days, and then we put the hip spica on. There are a number of strategies that we have used. So if we are unsure that there is enough callus on the repeat X-ray in order for us to then convert to a hip spica, we'll take the weight off the Thomas splint to see if the patient is uncomfortable, because again, the ability of that muscle to contract and control that fracture given its stability, is an indication of how stable it is. And again, you can then sometimes do almost like a push-pull, gentle push-pull with them awake. We have had incidences in the past where we've taken them to theatre to put them in the hip spica. And again, it was by doing it under image intensifier, again, a controlled push-pull type technique, that it shortened too much for our liking. And we put them back onto traction and then took them back a week later. So historically, we have done those stability techniques to trial that, yeah.
Right. Now, there's a few other questions I would like to whiz through because they're all really good. David Bennett has asked, how often do you wedge femur fractures in a spica? And he's put, Dr. Buddhev said once, but wondering about the rest. I think he means the rest of us. I'm going to say I've never wedged a femoral fracture in a spica.
No, so the report with the single leg, sorry, Steve, with the single leg spica technique, it's been well described in America, and they say it's up to 70% that need wedging, and that's why you keep a very close eye on them. So I see them at week 1, week 2, and week 4 for most of them. But it's all about that valgus mold, and I think my answer with this is very much it's with the one-legged spica that it can drift. I think if you go with a typical 2-legged spica, then that's less of an issue. But obviously, the children in the one-legged spicas are walking and mobilizing sooner.
I think one of the reasons why, so I'm a big fan of wedging. I think it's a kind of a lost art, really, particularly for tibias. I haven't wedged femurs. I think partly because I don't have pranay skills in putting those walking spikers on. It's something I want to do, but I've never done one. But as a result, I tend to manage much younger kids in cast, and they've got a greater remodeling potential, and the older ones tend to get nails in my practice. So I haven't wedged a femur, but I really want to give Pranay's technique a go. And if we're doing it in slightly older kids, then maybe wedging is helpful for that. And I'm a big fan of wedging.
Right, now, this is an interesting one, and it's Iggy Liu, who's a trainee from our region and specifically our hospital. And this one's relevant, actually. Do you guys use Thomas splints? So Claire's mentioned that she does. How about you, Pranay? How about you, Steve?
We've used them a couple of times, and I definitely see that we used to use it, especially during training. I see them being used less now. I think skin traction, especially because it's for a short period of time before I take them to theatre within the next 24 hours is okay. And it's all about what your nursing staff and your juniors are comfortable applying.
Yeah. We actually do use Thomas splints a fair amount. I think a bit like Pranay says, we've got a brilliant advanced nurse practitioner. She's kind of taught all the nurses how to do it and do it well. And so we often do it, but not as a sort of definitive management tool, but just for pain relief and ease of transferring and things like that.
And that's the same thing that we do, but it can be a problem when the experienced nurses, because often these guys come in at about midnight. Well, they don't really, but normally our specialist nurses are either hanging around to put the traction on, or it's about 9 o'clock, they've gone home. And sometimes we find that we've got people who can't do it. And it is very difficult. There are videos and things, but I'm not sure that it's something that people need to struggle on in the night. You could just do it first thing in the morning, in my opinion. Now, we've got Nathan Silver, and he asked a really cool question. And I said, you're not from the UK, are you? And he said, no, he is based in Jerusalem. He was asking whether any of you have ever put spikers on under conscious sedation, which is why I thought you're not from the UK. But have you done anything like this? So in North America as well, they put their spikers on in the ED, don't they? Any experience, guys?
No, for me, it's all about getting that valgus mold and control. So no, I've never had an experience of doing that.
Yeah.
I haven't undisplaced femoral fractures. Yeah.
Right. And that was tolerated well?
Yes, it was. It was, and it is something that putting a hip spica on in the clinic environment is something that I want to do more and more of, especially again for hip dysplasia. So, but again, in the painful, unstable fracture, no, I haven't done it. In the comfortable, undisplaced fracture, yes, I have done it.
Brilliant.
Just another point, Anish, is we've over COVID we've started using novel sort of plaster products. So we're using soft cast. Which can be unwrapped, as I'm sure Biscor sort of produce. But so that spike I put on yesterday, the underlayer is hard fiber cast, enough that we could cut through without using a plaster saw in these young children that scares them. And then the overlay, the colorful layer is a soft cast. So that's something else we've done differently in the last year or so.
Yeah, man, you guys are splashing the cash in Essex. I saw that camouflage plaster. We can't get that.
Mm.
All right. We've got.
I had a little bit of a shudder though when I saw the glitter on the cast though. Oh.
Come on. Right, Mohammed Mahmood and David Bennett have both asked, do you protect flexible nailing with application of a spica?
No. But I do use a Richard splint to stop the external rotation of the leg until they regain their quads function back and are able to control that. So probably 2 weeks.
Steve, Pranai?
One patient who had a flexible nail with osteogenesis imperfecta who had early sort of drifting of position that did not have a spica on. I took back to theatre and put a spica on purely because of the underlying diagnosis for protection. So I'm usually using nails so I don't have to put a spica on, and yeah, so I've never done both.
No, and again, personally, I haven't used spikers. I was using a cricket pad splint at one point, but then I just realized as that was just to try and slow the kids down. And I've kind of now moved to just a bulky bandage to treat me for 2 days. Right. And then we've got, what is the logic for using a different solid nail, IM nail, in these pediatric fractures? Why would a normal adult nail not be advisable? And I think, Pranay, you did address that really. So one is the entry point, but the other thing that you had in that table is the reamer. So some of these nails, although they might have a lateral entry point, you're using 12mm reamers, which in a pediatric femur, in my opinion, is a massive hole. So that's what the difference, I'd say, with the orthopediatrics reamer. And there are lots of adolescent nails, as you've said. Orthofix also make one, but that's why I'd say that's the difference there. Ahmed Nagy has said, what is the nearest time to remove the elastic nails or the plate? So for me, it's when the fracture's healed, and normally that's at about 6 months. Do you guys have any specific things for femoral nails and when to remove them?
Yeah, probably at least 6 months, probably no more than 2 years.
Even in these COVID times, Steve, can you really guarantee that?
Yeah, that's true. I mean, I work, so one of my colleagues is a fan of leaving most metal work in, so I think he generally plans to leave his elastic nails in anyway.
Okay.
And I'm kind of maybe coming around to that way of thinking. I suppose it might really screw up the adult orthopods later on if they need to put some intramedullary device in that femur, but most people don't need that, or they've grown so far that even with a hip replacement it's not going to interfere and so forth. So I'm not sure. So I usually do try and take them out, but maybe it's better to not do it, just leave them in.
Right. And guys, there are so many questions coming in, and I will try and answer them in the next talk, but there are a few ones that I think the group should answer. Is there a minimum number of spikers that should be applied in a unit to maintain competency?
I don't think, obviously with girth, sort of looming, we need to think about, where our skills lie, but these are basic trauma skills, and it is plaster application. So there will be, I think that every hospital should have a member of their plaster room staff that is competent in putting on a spica. And if that involves some degree of, demonstration or certification, which they all do anyway, that would be helpful. But I think as part of what we're doing with OrthoHub, we're hoping to produce a video on how to apply one of these spikers. It is very simple. As I said, I did one yesterday. I had 3 registrars in the room and they were all shocked as to how easy it was. And it's not difficult. That's why we've broken it up.
Your magic hands.
No, it's just breaking up into those simple things, like those simple steps that make it easier to apply. No, I don't think. I think if it's the best treatment for the patient, then there shouldn't be a minimum number. How many people are doing 5 femoral intramedullary nailings in a year, in a DGH or a trainee doing them? So I don't think that really works. It's trauma.
Yeah, I think putting a hip spiker on, someone in the audience might be able to correct me if I'm wrong, is part of the Stanmore course. I remember I had to do a talk on it a few years back. They didn't ask me back, so maybe it was a shit talk. But I'm pretty sure they do get taught that as part of the Stanmore course. They might, like I say, they might not do it very regularly since then, but I think it is something they're taught to do.
And just a couple more. And guys, what I was going to say is there are a lot of interesting questions here. We're not going to have the time to answer them today, but as you heard, there's this whole thing about Clubhouse next week, and there is going to be a continuation. So if you guys tune in then, I'm sure we can go through some of these questions then when we discuss the cases. Does anyone allow weight bearing on their elastic nails straight away? Anyone brave enough? No.
For the purely transverse length stable ones, I might let them weight bear as pain allows, but yeah, generally I'm with Claire. I not usually.
Yeah,
they don't usually want to walk anyway, to be honest. Even if you want them to, they don't.
yeah. I find those kids are pretty sensible. They'll start putting weight on it when they know it's time to put weight on it. They're not like adults who might try and do things too quickly. And that's why I stopped using any form of plaster or cricket pad splint. I just thought, actually, it's pointless. I'm treating me, not them.